Us to go live?
Yes, sir. Yes.
Thank you. Hello, Dr. Mukherjee.
Hello. How are you?
I'm fine, sir. Always.
Good afternoon, sir.
Good afternoon, sir. Lovely to see you, as always.
Good evening.
Good
afternoon,
sir.
Ganga.
Good afternoon.
Welcome, Nadine. Welcome,
Sir,
Nadine.
Natarajan has come.
So we have a visitor from the police department of Mumbai, is it?
Yeah.
Hi, sir.
NYPD.
Hello, everybody.
NYPD.
Yeah.
Sir.
Hello.
Sir, your entry is like that Dil To Pagal Hai movie in that the Shahrukh Khan jump at the last minute on the stage when people are waiting for the show to go live, and then suddenly you jump on the stage, right? Right, Dr. Purinder? His entry is always like that.
It's true. I agree with you fully. Dr. Natarajan is like that.
He was busy eating in a restaurant.
Dr. Agarwal. Dr. Agarwal.
Yeah.
Sir, we are live now.
Okay.
Okay.
Good afternoon, everyone. We are grateful to the All India Ophthalmic Society for organizing this wonderful international webinar and having helped the APOTS carry out this program, which will bring out several important aspects in ophthalmic trauma. Ophthalmic trauma, as we know, is a major cause of loss of vision and morbidity the world over. And it is vital to highlight this, not just amongst the ophthalmic professionals, but in general public at large. And many of those issues we will be discussing today. I will request Professor Mukherjee and Dr. Natarajan, the other chairman, to say a few words before we hand over to the moderators to carry out the agenda of the program.
Thank you, Dr. Brohan. It's my pleasure duty to thank All India Ophthalmological Society to invite APOT to have this trauma session in this conclave. And I must welcome all the speakers who are joining in this symposia on ocular trauma from different parts of the Asia-Pacific region. And as Dr. Grover has pointed out, the trauma is entirely a different thing. One has to deal with trauma as a different subject, because we know that primary repair is the best repair and total repair is the best repair whenever we want to give a good result to the patient. So for that reason, we should have, rather we must have one ocular trauma registry type of thing where people are working in this group. They are going to speak about it, and trauma registry where we can put up all our cases so that we can come to a consensus and develop a protocol where we can have a standard method of treatment and the training on ocular trauma. These are the few topics that to be brought out today, and there are experts who are going to speak on this topic. Thank you very much, and welcome all of you to this conclave.
Thank you. Thank you, Ashok, and thank you, Dr. Mukherjee, for giving opportunity to Asia Pacific Ophthalmic Trauma Society. Thanks to Namrata and Maipal, All India Ophthalmic Society, for having APOTS. And I'm glad we have our scientific chair, Dr. Gangadhar Sundar, and our Rupesh, who are going to moderate, and Purendra Besan, Vice President of Ocular Trauma Society of India, to be a co-chair. And I think I'm happy this year, even though 2020 was Corona, but I think ocular trauma has been given a lot of importance right from WOC. WOC, we had 6 important symposiums. I'm glad again myself and Gangadhar and the rest of the APOTS and OTSI were involved along with the ISOT for scheduling. I'm glad AIOS has given the importance, and we are celebrating the silver jubilee of Ocular Trauma Society of India. And this is our centenary year of Asia Pacific Ophthalmic Trauma Society. And with this, I request now Gangadhar Sundar, Purendra, and Rupesh to take over.
Thank you, Professor Natarajan. And it's a pleasure, and Professor Grover and Dr. Mukherjee. It's indeed a pleasure of APOTS, as very rightly mentioned by all 3 chairpersons, for this opportunity to work with AIOS on this very important topic of ocular trauma. we have been looking at always, and my agenda for AIOS was to give it in either Hall A or Hall B. So this time I'm very kind that Dr. Namrata has given us Hall B, and we are not always Hall G, right, Dr. Natarajan and Dr. Mukherjee? We
Yes.
are always Hall G, but this is the first time we have been promoted to Hall B. So I think that's where I think we can all witness where the trauma is moving forward. But I think we need to move forward with this symposium where we have got all the star speakers from our own Asia Pacific region. We have speakers from India. 4 of those speakers are from India, starting with Dr. Mehul Shah, who is one of the expert on ocular trauma and working in area in Gujarat. Then we have Manish Bape from Nasik. Then we have Dr. Rajendra from North India. And then, of course, we have then international, then we have Tarjani from LV Prasad, who will be joining us soon. And then we have 4 international speakers from China, Taiwan, Nepal, and Australia. I think these are the kind of speakers which we have got, and also the different disciplines. I'll maybe request Dr. Gangadhar to give a little bit of overview before we go live.
Thank you, Rupesh. Thank you, everybody else, for joining us. As Rupesh mentioned, we have a good expert speakers and panelists. The purpose of this particular session is education. Education is nothing but learning and sharing at the same time, which transforms practice. And those of the speakers who are masters here are going to share the experience. And finally, where we should end up with is activism. And I think Dr. Grover, Dr. Natarajan, Dr. Rupesh, Dr. Annette, all have been really proactive in trying to change the way we practice ophthalmology, ophthalmic trauma care, and where we should probably be headed towards eventually is prevention rather than management of ophthalmic trauma. We have a galaxy of speakers, and I'd like to invite Dr. Rajendra Maurya to start off the session to share with us what are the emerging trends and concepts and patterns in ocular trauma. Dr. Maurya, please. A discussion after 4 presentations of 12 minutes each. Dr. Maurya.
Good afternoon, chairperson, co-chairperson, and moderators, all speakers and participants. I am thankful to Dr. Namrata Sharma and Dr. Gangadhar for inviting me in first International Ophthalmic Conclave. My topic of presentation is ocular trauma, changing patterns and landscape.
Dr. Maurya, can you enlarge your screen if possible? Put the full screen option.
Okay, I'm trying, sir.
Okay.
So my topic is ocular trauma, changing patterns and landscape. Ocular trauma, once described as a neglected and underreported disorder, has recently been highlighted as one of the major causes of acquired visual impairment and blindness. Ocular trauma constitutes 7% of all bodily injury and 10 to 15% of all eye diseases. More than 1.6% people are blind due to ocular trauma worldwide. It has been reported that 90% of the ocular injuries are preventable. For the development of effective preventive strategy, proper knowledge of clinico-epidemiological pattern of ocular trauma is required. Epidemiology of ocular trauma varies from country to country, depending on the geographical location, literacy level, socioeconomic status, lifestyle, and cultural practice in the society. And these factors are constantly changing. Severity and pattern of ocular injury depends on the traumatic agent, circumstances, and mechanism of injury. Ocular trauma can occur virtually at any setting, at any age. Children are more vulnerable to ocular trauma. According to the annual report of NSBP India, the major cause of pediatric ocular trauma is sports and recreation-related activities. Depending on the period of popularity, sports are traditional games like gulli danda, kabaddi, bow arrow, and modern games like cricket, hockey, boxing, wrestling. And depending on the anticipated eye damage, the sports are divided into low risk, high risk, and very high risk. The modern games are mainly high risk games. A young child having a gulli danda injury showing a rupture of the left glove. Another case of the penetrating injury caused by bow and arrow injury. Hockey and cricket is a modern and most popular game in India as well as in other countries. The famous hockey and cricket players have severe eye injury by ball. Here is a multiple oculofacial fracture with globe rupture caused by cricket ball. Pattern and severity of ocular damage depends on the velocity, size, hardness, and weight of the ball. Kite, that is patang flying, taken as an exciting and competitive sports, has tremendous popularity in North India. Kite flyers may sustain direct injury by kite string or indirect injury due to fall from height. Here is a cranio-orbitofacial trauma due to fall from height while flying the kite. Child was having a retained orbital foreign body, that is asbestos cyst, which was removed by multidisciplinary approach. In present scenario, excessive use of mobile phone and electronic gadget is emerging as a cause of ocular trauma due to accidental battery explosion. This child having polytrauma due to mobile blast. There is a traumatic amputation of finger and laceration of upper eyelid and cornea. The cornea and eyelid was repaired and foreign body were removed. The prevention of battery blast suggestion is never use mobile while charging. Avoid overcharging of your mobile. Ocular face hook injury is a common recreational human activity. Management of face hook injury is quite challenging and difficult because there is a risk of severe damage while retrograde removal of the face hook. Child having a corneal face hook injury, CT showing the face hook was in anterior chamber, which was removed by a vertical incision given on the entry side on the cornea. Another face hook injury of eyelid, which was removed by advancement and cut technique. SL2 violence has been increased twice within last 2 decades, and assault-related ocular injuries are often grievous in nature, and its prevention is very difficult. There is a case of orbitofacial trauma due to physical assault, showing multiple orbital fracture, which was repaired by titanium mini plate. The gunshot injury showing a double perforation of right eyeball. Another case of assault-related cranio-orbital trauma in a tribal person that was injured by a metallic arrow, which was removed by multidisciplinary approach by ophthalmologist and neurosurgeon. There is a changing pattern of war-related injuries. War injuries are multi-system mass casualties associated with high incidence of penetrating injuries, and heavy wound contamination is another dimension. There is a changing pattern in incidence of ocular injuries when we see from the First World War to recent, that is urban Israel war and Muslim countries war. They are showing increasing trends in the incidence of ocular injuries during war. There is a changing pattern of weaponry use in warfare. That is from machine gun and grenade. Now there is a automatic nuclear weapons, biological weapons are available. For management of the war-related ocular injuries, a coordinated, specialized, and multidisciplinary approach is necessary. And soldiers should be provided a good quality protective devices. Animal-related ocular injuries are mainly caused by livestock animals like dog, cat, and cattle. Wild animal attacks have now become rare. I have seen only one bear attack injury in my whole 25 years of ophthalmic practice. This patient was having multiple orbital and orbitofacial fractures with laceration of the forehead, which was repaired with multidisciplinary approach along with the maxillofacial surgeon, neurosurgeon. And cow horn injury showing scleral rupture with phacocyl. Another case of cow horn injury with fractured posterior IOL, dislocated subconjunctivally, and broken haptics inside the anterior chamber was successfully removed. Dog bite wounds are always a complex in nature and difficult to manage because the dog carry number of germs in their oral cavity and risk of rabies transmission. This is eyelid avulsion due to dog bite, which was managed surgically. Another case of dog bite. Management of dog bite includes the aggressive wound irrigation, selective debridement of the dead tissue and scab, anti-rabies and anti-rabies immunoglobulins around the wound site, and wound repair, primary repair is preferred nowadays. Previously, it was recommended that secondary repair, but to get the better cosmetic result and proper wound position, we will try to repair dog bite injury primarily. Another is a newborn presented with me a history of cat claw injury just 1 hour after his birth, which was repaired and with some deformity. Another case of cow hood injury. Road traffic accidents have increased tremendously in last 2 decades due to growing number of vehicles, new drivers, congested and poor quality of road. The number of road traffic accidents increasing in almost all developing countries, including India. The road traffic related ocular trauma, there is a severe lid laceration and globe rupture. Patient was lid repair and globe repair was done. To give a cosmetic, we will put the custom fit prosthesis. Road traffic related crust injury of the left eye and periocular area. The principle of management was anatomical identification, thorough debridement of dead tissue, proper approximation of the tissue, and repair by layer. Prevention of RTA-related injuries. One should avoid the driving under alcohol consumption, fast driving in night, overloading, use of mobile phone, eating or drinking, and smoking while driving. The domestic and agricultural injuries. This lady, a young girl having cooker whistle-induced injury. There is a laceration of the eyelid and total rupture of globe. There was no light perception. Another case of globe and lid injury with harvesting fan. And patient was managed. Message is never excise the globe, even there is no light perception. Preservation of globe offers advantage of positive psychological impacts to the patient and his relative. The service recommendation towards the ocular trauma, there should be a mass health education and spreading of awareness regarding the risk of ocular trauma, morbidity caused due to delayed presentation, and need to adopt safety preventive measures like compulsory wearing of appropriate protective devices, safety goggle, helmet, seatbelt. Primary healthcare providers should provide initial treatment as early as possible and then refer complicated cases immediately to the nearest tertiary care center. Early and meticulous repair may give good visual outcome. Government administration can play important role in prevention of ocular injury by imposing strict rule against the assault. Prevention of assault-related ocular trauma needs modification of violent behavior, resolve the conflicts as early as possible, strict control over alcohol, illegal drug use, and legislation limiting the proliferation of firearms and weapons. Multicentric study would provide better insight to the problem. That is research recommendation. In order to find out the efficacy of treatment outcome, vigorous monitoring of outcome parameters is required in prospective manner. Therefore, a prospective study is another aspect may be taken for prevention of ocular trauma. Thank you.
I think this was a wonderful talk by Dr. Moria, and this has really opened the platform for today's conclave. And really appreciate your time and the way you presented. You really put up a proper picture. but we'll come back to discussing a couple of critical points on this topic. But before that, we'll continue with Dr. Annette. Annette Hoskin is one of those optometrists who is pursuing PhD on ocular trauma. So we have seen people pursuing PhD in all different topics, but I think she's one of those rare person who is doing a PhD on ocular trauma. And she has done wonderfully well with APOTAS, and she is our champion for prevention of ophthalmic trauma, as Dr. Ganga very rightly pointed out at the beginning of the symposium. So over to you, Annette. Maybe Dr. Maurya, you can stop sharing screen. Then
Yeah,
Annette,
yes, sir. I'm topic.
stop sharing, and then Annette can share the screen. Yeah, Annette. Annette, over to
Thank you.
Thank you.
Thank you so much for the wonderful introduction. And Dr. Morea, as you said, has provided a really lovely background to what I want to share today. And so what I just want to briefly take you through is some of the areas that we've been focusing on in researching how we can better understand and prevent eye injuries, but also how we can manage them and ensure better outcomes. So these are some brief disclosures. So what I want to talk about is eye injury registers, past, present, and future. So the first and most important question is why we collect data. And if we don't understand the answer to that, we're not going to be able to collect the data. Then I want to talk about how we can do that, and then give some examples of what we've done in the past in terms of eye injury registries, and just a little bit of a look into the future and what we might do next. So certainly looking at the complexity of ocular trauma, I think we all know and we're all aware that eye injuries are often an orphan discipline. And I think this very recent paper that was published in Lancet, which talks about global eye health and vision beyond 2020, for me is quite an interesting paper. It highlights not only all of the diseases, but all of the other potential biological determinants. And you can see that trauma features in all three later stages of life. So things like this are very important because they bring the question of trauma to the front, and it helps us to be able to promote the need to do better in terms of trauma. So as I said at the beginning, if we're going to collect data, we need to make sure that the effort and the reward are balanced, and we need to really understand why we're collecting the data, because there's no point in collecting data if we don't have a clear sense of what our outcome is and what we're trying to achieve. So for me, the reward in this is about reduced incidence as well as improved outcomes from trauma. So through better management and treatment of trauma, we're likely to improve the outcomes, but also with the right data, we can reduce the incidence of outcomes. And I think one of the introductory comments was total repair is the best repair. And in my mind, no repair is the best repair, because we don't want to have the eye injury from the beginning. So I just have two brief examples, one relating to detergent pods. So these little pods are often used in dishwashers, and children were getting a hold of these and bursting them, and they would end up with quite severe chemical burns as a result. So this was a clear example where data was used in collaboration with government organisations to try and have better labelling on products. The other example related to some foam that people were using and spraying, and there's all sorts of celebrations and things that people do around those celebrations and the sorts of products they use. And I know Diwali and Holi, these are other festivals where people are using products that can potentially end up with trauma or eye irritation. And as a result of this being publicised quite widely in Israel, they were able to minimise within a year the use of the foam, so that from 1 year to the next they had a reduction. So using the data and using the media, they were able to educate people about this. So there's definitely a number of things that we can do and a number of ways that we can use data to be able to prevent, and this hierarchy of needs talks about how we can best approach. And if you think about the example of fireworks, which I'll talk about a little more in a moment, if we can eliminate things from sale, then this is the gold standard. So this is the way that we're going to reduce injuries completely. But in some contexts, it's very difficult to eliminate them altogether. So we should look at alternatives, or we should look at restrictions, we should look at education, and then the last line of defense is some kind of personal protective equipment. So again, this is just ways that we can use data to effectively prevent injuries from happening. If you look at some work that we did, Rupesh and some other colleagues and I, we looked at eye injury registries that have been used in the past and tried to understand what the success factors are. And as you can see from this table, the US eye injury registry features quite highly. And in fact, many of the other registries have used the US EIR as the basis. But certainly with our research and from our understanding of past eye injuries, US Eye Injury Registry was the most successful in terms of the data that was provided and the publications that we used that were successful in preparing and presenting different interventions. So if we look at what's happening now, many of you are probably already aware of the collaboration that's happening between many of the societies that are present today. And that collaboration, AIOS, is a registry for us to try and help collect data across a wide spectrum of countries. And so as we heard from the first speaker, certainly the different sorts of eye injuries will change depending on the geography, the sorts of activities that people are doing. And the best way for us to get a good understanding of that is to have a uniform registry that we can collect data on using the same terminology, the same basis for data collection. It's the only way that we can really get a clear understanding more globally. So using iGates 2 years ago, we collected data around fireworks. So we used that to try and get a better picture of where eye injuries were happening from fireworks, and the picture that we clearly got. And I'm sure many of you are aware from an Indian perspective that around Diwali, this is a key time that things happen. But also in countries like the Netherlands, where they have a lot of eye injuries around New Year's Eve, and in Argentina. So many of these other countries will allow fireworks for a very short period of time. And if you see the spike in eye injuries that happen in the Netherlands and Argentina, it's very much around New Year's Eve, as opposed to what we have in India. And of course, many would be aware of Chinese New Year and the use of fireworks. So it's really important. And again, understanding exactly when and where these injuries happen enables us to go and have a conversation with government and legislators so we can look to prevent these eye injuries. So this is just a really brief summary of the data that we gathered relating to eye injuries from fireworks. And similar to other studies, we found children, bystanders and males were often most affected. I think the thing about fireworks, and again, many of you are already aware, is the devastating loss of vision that happens. It's one of the most severe vision losses that we see in any type of eye injury. So in terms of where we might go next and what the future looks like, some of the things that we're currently working on, we have a survey currently looking at terminology. Now already with the Ocular trauma score and the Birmingham, the BETS terminology system, we have a very successful, very widely used set of terminology. But we know that there's some limitations. And one of the key limitations is that those definitions really are limited to injuries to the eye. They don't include the true broader definition of ophthalmic trauma, which is not just the globe, but everything around the globe, the adnexa and the lids, etc. So for us, trying to, in some of the initiatives that we're undertaking, we're trying to gain a better standard of data collection, a more uniform set of data collection, and a wider definition. So in doing so, we feel like we can get a better handle on exactly the sorts of injuries that are happening to do those things that we said we want to do in terms of reducing the number of injuries, but also managing and treating them more successfully. So this graphic helps you to understand in terms of the current eye terminology system, they're really limited to the injuries to the globe, and what we're looking to do is to try and broaden that. So we have adnexal injuries, which, as you're all aware, can have significant consequences to the final visual outcome for the person. So shortly we'll be launching iGates 2, which is the revised version based on our learnings from the first lot of data that we collected, is trying to use a system of data collection that will enable us to more systematically collect data, but also trying to use big data and artificial intelligence to collect data more quickly and more easily. One of the things we're looking at is a schematic where you're able to draw and very quickly download a sense of what the injury is, and it translates that using an algorithm into all of the data that would previously be needed to be hand or manually collected. So it's really the opportunity to come together with a number of different groups that we're trying to establish. And already we have a large number of collaborators from India and many other parts of the world. But really for us, I think the power is in collaboration and our ability to collect data from a large number of groups. And ultimately for me, I feel like if we can get data more quickly, we'll be able to address the different types of injuries that are happening and more effectively intervene and prevent them where possible. So I'd like to acknowledge my collaborators, and of course Rupesh is here on the call with us, but also many of the different institutions that have contributed data, and APOTS for their support, and All India Ophthalmic Society and the organising committee. So thank you again.
Thank you, Annette. Really appreciate your concept of no repair, and you challenged Dr. Moria about total repair. Dr. Purinder, you would like to go and introduce our star speaker for the day?
Dr. Mehul. Yeah, thank you, Dr. Agarwal. And very nice talk, Dr. Annette. And really you have sensitized us for trauma registry all over the country, and in this presentation and from all over the world, we should add more trauma registry. I would like to introduce our star speaker, as rightly been said by Dr. Rupesh, Dr. Mehul Shah. He will be speaking on education and training in ocular trauma. And he is the director of Drashti Netralaya, and he is the general secretary of Ocular Trauma Society of India. A wonderful speaker, wonderful person, and has got lots of publications in ophthalmic trauma to his credit. And he has started the fellowship program of training in ocular trauma at his center. Welcome, Dr. Mehul. We look forward for your presentation.
Mehul, maybe you unmute yourself first.
We are not able to hear you, Dr. Mehul.
Yeah, okay. Thank you. Thank you, Dr. Purendra, for your kind words. And thank you, Professor Namrata and APOTS, Dr. Ganga and Rupesh, for allowing me to be here and share our experience regarding education and training in ocular trauma. As we all know that it is very important to and already highlighted that incidence of blindness caused by ocular injury is very well known. Every year, 55 million people in the world suffer from eye injury, restrict at least their activity for more than one day. 750,000 persons with ocular injuries require hospitalization at least for 1 day and include 200,000 open globe injuries. 1.6 million blind people, 2.3 million people with bilateral low vision, and 19 million people with unilateral blindness. It will cause the economical and social burden. So we would like to have more people to treat ocular trauma in more effective and efficient manner. But as we all know that the medical and surgical education is something different ballgame. It is still little difficult to train people in ocular injuries because of certain reasons. Because it is an emergency, it is not an elective part, lack of human resources, limited access to the efficient ocular trauma care services, and lack of coordination amongst various departments like subspecialties of the ophthalmology and other department where other experts are required. The objective is to create the task force to fight the blindness because of ocular trauma. Clinicians who understand the ocular trauma well, this will need a person who can handle the primary point of contact and manages emergency management or coordinate the team management. Once emergency is over, the management by subspecialty may be taken over and maybe multiple players of the team should come. The challenges in training is awareness amongst the ophthalmologist itself, because very few people want to have a career, this as a career option. These are non-elective patients and people think that it is financially less rewarding. So there are very few people who are coming forward for this training. There are limited number of ocular trauma care centers also. So when we started in coordination with the Ocular Trauma Society of India, we have given a lot of thoughts and try to understand the different training models. And in many of the institutions, the training tenure was more than 2 years or 3 years rotationally from one to another department, because the fellow has to be expert in all these departments. But in Ocular Trauma Society, we decided to have a model to any person who is undergoing training. If we extend the tenure for 6 months, then we consider them as an ocular trauma fellow, and not training one trauma fellow for all subspecialties. And so we started getting some of the trainees and we started treating people. This method has to be different than the elective surgery. Emergency attendance is must for all ocular trauma fellow. Primary care by ocular trauma fellow, either for trivial trauma or if it is a severe, the trauma fellow has to create the team and teamwork will follow. And referral to the respective department like retina, cornea, glaucoma, or if required, the other part like neurology, neurosurgery, maxillofacial surgery, all teamwork has to be created. During their emergency posting, they examine, they do assistance and independent repair once the skill is acquired. And during subspecialty training, depending upon the specialty of ophthalmologist, especially surgical given under observation and then independently. Rotational posting for different departments to learn the nuances of various specialties for medical and surgical protocols. As a part of surgical training, primary repair of open globe injury or adnexal injuries are more important, or removal of ocular surface or intramural foreign body to start with. For that particular, it is very important to have a training infrastructure for documentation and assessment. Once the fellow is documenting, and then expert person will access those data, and so that they can correct the problems with the ocular trauma fellows and improvise the conceptualization. Training infrastructure for surgical recording, self and expert assessment also is very, very essential. Ocular Trauma Society has trained 4 fellows till now. 3 has been trained by us and 4th fellow is undergoing training with Dr. Shakin Singh. And we are planning to take many more fellows at all our centers. The impact of the other aspect on the practice. Ophthalmologists, once they are trained with ocular trauma, they feel very much confident for other subspecialties also. Fear for frightening sight is also gone. These are experience sharing by ocular trauma fellows by Ocular Trauma Society of India. Particularly, they said it is very important to gain a full-fledged confidence in day-to-day practice and having edge over other fellow ophthalmologists. And fellowship has given the meanings to the career. This is one of the experience shared by our one of the fellow.
So Dr. Mehul, his audio is not coming. The person, maybe you want to adjust something on your computer, because at least I can't hear. Yeah, just
Not coming.
Not coming still.
सर एक बार स्क्रीन से स्टॉप कीजिए, उसके बाद शेयर स्क्रीन करते टाइम शेयर स्क्रीन विथ साउंड ऑप्शन सिलेक्ट करके शेयर कीजिए, साउंड आ जाएगा।
It was very important that to integrate the ocular trauma, particularly during routine residency program. Normally, residents are not very much sensitized to this program, but sensitization to all resident doctors regarding ocular trauma and emergency documentation according to BTTS or IGETS, documentation of ocular trauma score and pediatric ocular trauma score, and training for primary management has helped all the residents to learn and to encourage the interest in the ocular injury cases. And these are experience sharing of a few of our resident doctors. In summary, the chance to worst case scenario, including no light perception, has to be given. This they understood. The standardization of documentation according to the required format as learned by these people, and timely intervention according to the standard protocol and guidelines is important, and persistent to the trauma case with multiple surgeries and with good hope will create a good impact. That's what they have learned. Particularly research. Ocular trauma fellows and residents are involved in prospective and retrospective research regarding ocular trauma, published several articles and presented during national and international conferences. So our Ocular Trauma Society fellows have presented 63 presentations during national and international conferences, and they have 14 publications in their name, while our 34 resident doctors have presented 74 presentations in various forums, with having 28 publications in their names. These are the presentations by ocular trauma fellows, and these are the publications by fellows and residents where they are primarily involved. Future of ocular trauma education, as suggested by IGETS, ocular trauma trained fellow present in each trauma center attending emergency cases. His or her scope of working will be during primary management, coordinating amongst the ophthalmology subspecialty as well as other department, and documentation according to standard terminology, and keeping all data up to date, including follow-ups. Thank you.
Thank you, Dr. Mehul Shah. I mean, your work is truly inspiring, not just from the quality of the work that you do as an individual, you do as a team with Dr. Shreya, and you do as a team with all members of Drashti Netralaya, but you've now taken it a bit further and translating it into education and training, setting standards, and it's truly inspiring, and we hope to interact with you and learn from you. So global platform to raise standards of care and training in ophthalmic trauma. Thank you very much for accepting our invitation to talk. It's my pleasure now to introduce Yeah, thank you. It's my pleasure now to introduce Dr. Eli Pradhan from Tilganga Hospital in Kathmandu, Nepal. If you want to know the value of the talk she's going to give you, all you have to do is Google imaging and ocular and adnexal trauma, and it is the leading chapter in the iWiki of the American Academy of Ophthalmology, written by her a couple of years ago. And she's going to share with us her experience and knowledge into interpreting various forms of ophthalmic trauma imaging. Dr. Eli?
Thank you,
Dr.
Dr. Ganga.
Stop sharing, please.
Dr. Mehul, can you stop your screen share? Then we can upload slides of Dr. Eli.
Thank you. Thank you, Dr. Ganga and Dr. Rupesh for inviting me, and also Namrata ma'am. Yeah, okay. So Dr. Rupesh has shared my screen. So this is this is about diagnostic investigation in ocular trauma. I'm from Tilganga Institute of Ophthalmology. No financial disclosure. As you all know that imaging is very important to assess extent of injuries because of surrounding a periorbital soft tissue swelling and other associated injuries, and physical examination glove is difficult, especially in case of acute trauma, as patient cooperation may be limited by unresponsiveness, altered medication or sedation. Next slide. So we have various techniques like plain X-ray, ultrasound, ultrasonography A and B scan and UVM, computerized tomography scan, magnetic resonance imaging, and optical coherence tomography. Plain radiograph, it has 64 to 78% of sensitivity for orbital fractures, but this value is much lower for soft tissue injuries assessment. It is the first step for metallic intraocular foreign body due to its accessibility and low cost. For direct visualization, 2 exposures are necessary at right angles. One is AP and lateral view are taken. And this picture is showing radio-opaque foreign body in left orbit. Another one is limbal ring. Although it is obsolete at present, it is made up of either silver or steel, which is suitable diameter sutured to limbal limbus. X-ray is taken with metallic limbal ring or contact lens with radio-opaque marker over cornea. As you can see, these are the foreign bodies. There are advantages and disadvantages. Advantages are it documents the presence and number of metallic foreign bodies in higher orbit. It defines orbital wall and skull fractures very well. It's cost effective. It has the documentary and medical legal role, which is very, again, important. However, it is less specific in foreign body localization, cannot identify radiolucent foreign body. It fails to show existence and extent of penetrating or blunt trauma. Another one is ultrasonography. It is non-invasive, inexpensive, non-ionizing, and easily performed imaging technique. Is useful for evaluating eyeball measures, layers, and contents. It's 98% sensitive in detecting intraocular foreign body in appropriate setting. And this one is, the lower one is a scan showing highly steep rising echo spikes with high reflectivity. And this one is highly acoustic, contrasting with acoustically clear vitreous. So this is the foreign body here. And now this one is moderate to low echogenic reflectivity and highly mobile, which disappears in low gain. This is the vitreous hemorrhage, and this is the next one is ultrasound B scan showing dislocated lens. Next, please. Now this one is this like an V-shaped, it is echogenic lines. It is forming. This is the sign of acute retinal detachment. Echogenically. It's consistent with blood, and this one is this is the choroidal hemorrhagic choroidal detachment. Next slide. So advantages and disadvantages of ultrasound. Again, it is useful in opaque media. It detects and localizes radiolucent foreign bodies. It also shows that lens position and zonal integrity can be noticed. And it is useful intraoperatively in deciding the scope of primary repair. However, it is difficult to localize deep-seated foreign bodies, difficult to perform in open globe injuries. Extraocular muscles are not clearly defined, and limited visualization of optic nerve and retroorbital structures, and poor detection of scleral tissues. Next one is ultrasound by microscopy or UVM. It is imaging technique that uses high frequency sound waves to produce high resolution cross-sectional images of anti-segment up to the depth of 5 millimeter. And in case of trauma, it can visualize angle recession, cyclodialysis, donor dialysis, hyphema, scleral laceration, and intraocular foreign body, as you can see here. It also shows, it can show appearance of foreign body surrounding tissue, also the exact location, size, and nature of intraocular foreign body, much better than conventional low frequency ultrasound. It is also useful for detecting and localization of small, superficial non-metallic foreign body, which is usually missed either in CT or conventional ultrasound. This is the highly reflective intraocular foreign body in the inferior angle with echoes. Next one. Now, next one is the computerized tomography scan. It is considered the best imaging technique in ocular orbital trauma because it assesses intracranial, facial, and ocular structures. It is available imaging option in almost most of the emergency services in main hospital, and unenhanced orbital CT scan is the first choice to evaluate orbital trauma. And if vascular injuries are suspected, an enhanced CT is recommended, indicated, also useful when blunt or penetrating trauma is suspected. So these are the different structures which we see. All structures which is shown here. In case of open globe injury, the changes in, this is the right eye, the contour of the globe is lost. This is the flat tire continuity, and intraocular air and intraocular foreign bodies can be seen in case of open globe injury. And it is definitely the first choice when metallic fragments are suspected, and like in this one, it is seen very close to the optic disc, and its sensitivity is less, however, for glass and wooden materials, which can appear as hypoattenuating structures that can be confused for air bubbles. Without clinical history or ocular examination, CT scan has 75% sensitivity and 93% specificity for open globe injuries, diagnosis if there is complete ocular examination previously. And if there is hypotonia with no clinical evidence of anterior perforation, it helps to evaluate posterior segment evaluation properly. Like in this case, this has the left dislocated lens is seen in the axial scan of axial CT scan. Advantages: it detects soft tissue injuries and orbital fractures precisely. It has easy recognition of intraorbital and ocular air. Clearly defines most radiolucent foreign bodies. Also has exact localization of foreign body. We can also do simultaneous examination of brain and paranasal sinus. Contrast in her CT is valuable in suspected vascular trauma. It also detects optic canal fractures. However, thick CT slices may miss small metallic foreign bodies, and multiple tightly clustered metallic foreign bodies may be obscured by artifacts and fails to delineate wooden foreign bodies where MRI is important. Now, the MRI is indicated to visualize optic nerve and soft tissue in case of visual loss or when there is ocular mobility impairment. However, it is contraindicated when intraorbital metallic foreign body is suspected. And best option for detecting non-metallic materials inside the globe when CT fails to find is the MRI. It must be done to assess optic nerve injury if suspected, which is assessed by T2 high signal intensity signal. Like, yeah, next slide. So this picture, the first one, A and B, it shows only the low attenuated defect, but how it fails to show any definite foreign body. And the lower one, B, C, and D, it shows there's infection surrounding low signal foreign body here, this one and this one. And during surgery, this a small piece of wooden foreign body was removed. So advantages: better soft tissue delineation, quite sensitive for visualizing small amount of blood, excellent visualization of posterior fossa, better resolution of low density objects like vegetative matter and wooden foreign bodies, and also optic nerve laceration is also has better resolution or avulsion at intracanalicula portion. It detects optic nerve swelling as well. However, it is less helpful than CT in evaluating bony abnormalities. Longer scanning times needed and cannot be used if there is suspicion of metallic foreign body. Optical coherence tomography, it is another powerful non-invasive tool for evaluating macula, especially in case of macular trauma, because it provides detailed images of anatomical structure of the eye for diagnostic purposes, or also monitors various macular and chororetinal pathological changes, particularly in acute traumatic maculopathy. So this is the spectral domain OCT, imaging after trauma. This is the outer retinal layer swelling with preservation of the inner layer, disruption of outer retinal nuclear layer and inner and outer segment with cystic disruption at the outer plexiform layer. The next slide. This is again spectral domain showing foveal thinning in all the layers after systemic steroid therapy for 2 weeks. Although retinal splitting in the foveal region was resolved, it shows the outer layer shows disruption of the outer foveal layer under the fovea. Next. So these are the pictures. The first one on the left side is this is the cystic changes on the fovea following blunt trauma, and on the right side this is the hemorrhage at the foveal region with the back shadowing exactly at the fovea because of the hemorrhage exactly at the macular region. This is because of the blunt trauma. So therefore, the ocular trauma is one of the most common reasons for ophthalmology consultation in emergency department. USC is non-invasive, simple, and effective diagnostic method which enables visualization and evaluation of intraocular injuries in opaque media. CT orbit can detect many abnormalities and also complements bedside ophthalmic examination, which are usually limited in the setting of trauma. And MRI is an important modality, especially in case of soft tissue assessment or organic foreign bodies, and OCT, the main importance is in blunt trauma. And thank you very much again for giving me this opportunity. Thank you.
Thank you, Dr. Ali. That is really very comprehensive. It's a tough talk to cover in 12 minutes. You did a great job. Once again, I refer all of our members and attendees to visit iWiki to look up this topic on ophthalmic trauma imaging. I'm warned by the organizers we are running out of time, but for the first half, but I'll invite the three chairs, Dr. Natarajan, Dr. Grover, and Dr. Mukherjee, just to summarize with one or two pertinent points from the four presentations. Dr. Mukherjee, would you like to start? Dr. Natarajan? Grover, please.
I think Dr. Maurya has summed up nicely and given us the complete spectrum of the ocular trauma, starting from the regular trauma that happens in the domestic setup to the warfare. But I entirely agree with Annette that we must have the advocacy, that means prevention of this trauma, rather than a trauma to happen occur. For that matter, actually, we have taken up a lot of projects from the Ocular Trauma Society of India and the Government of India also. For RTA, road traffic accident, the Traffic Authority of India, they have put in 2017 a strict rule for the driver, and that has brought down quite a bit of this road traffic accidents. Similarly, the firecracker injury, we have, though we are trying to put up a public litigation on this process, but this process is going on for quite some time. We do not know when we are going to put it across the table in the court. Now, another point that is very important in India, particularly in southern India and eastern India, is the tuna packet injury. The tuna packet injury is very common in children, and they produce chemical injury to the extent almost the patient go blind. And these tuna packets are such a flimsy packet that when they try to open this one, they burst open, and all the tuna just spill over onto the eye or the face, and they produce the chemical injury. For this, actually, recently in our last symposia from the Ocular Trauma Society of India, we have fixed that 3 societies will work together. One is the Ocular Trauma Society of India, Corneal Society of India, and Steroids. The 3 societies together, they are planning how to promote this advocacy against the tuna packet injury. We have taken a different type of approach this time because we have seen it, and our experience has shown also that if you go for the litigation, it takes a longer time. Rather than going in for the litigation, if we can educate people and create more awareness about these dangerous conditions, and you can demonstrate to them indirectly through the photographs or through the films, so that they know that what can happen to their eyes if they do not take proper precautions. So we are changing our approach a little bit because litigation, as I told you, that it has to go in a longer process and it takes longer process for come into act. So this process has to be changed. It has to go in the form of an awareness creation through various organizations. We identified those organizations and we will go according to that. So advocacy, as I always say, that is most important in the management of the trauma.
Thank you. Thank you, Dr. Mukherjee. Dr. Grover, would you like to make a couple of comments based on the 4 presentations before we move on to the second half? You're muted, Dr. Grover.
Yeah, we've had some very important ground covered in these talks. I think Annette really spoke about the role that we can play in prevention with the registries, with the advocacy. And I think that is what Dr. Mukherjee was stressing. What Asia Pacific Ocular Trauma Society has done is brought people together. I think we must appreciate the effort of this society in bringing people from all over the world together in the cause of ocular trauma or ophthalmic trauma. And that is something which is going to really bring about a change. And the efforts that are being made at collecting the data and at preparing the advocacy material will have a material bearing all over the world. And that is the role that we look at all our societies for doing, and Ocular Trauma Society of India, APOTAS, and the International World Ocular Trauma Society. They should all work together towards this goal. And I think that is something which we are looking forward to from these joint meetings. Thank you.
Gangadhar, I would just like to add one line here.
Yes,
that if we go somewhere to just project ourselves that we are creating awareness or we are going for the legislation of prevention of ocular trauma, first thing they ask, what is the incidence? Can you quote us the incidence about this particular problem? Most of the time, we cannot have those incidences in our hands unless we have a proper registry from where we can have the incidences and put across to them.
Yes, sir. I think the point is well taken. And each center and iGates has started to do that just precisely. Just that we have to motivate all of our members to actively contribute to the iGates registry. It's not just enough to be a passive member of the society, but an active member and contributor. In the interest of time,
can I make a very quick comment, if you don't mind? I know we are running out of the time and I'm the moderator and timekeeper as well. But very quickly about the incidence of trauma, and which is a very important point. And I think what we need to gather our act is particularly the major institutes in India, from north to south and east to west. They all need to come up with their act together, get a standardized data entry for done. I know a lot of resources are required and it is easier said than done. It's not an easy task to do a data entry. And whenever the things have come up, a lot of funding is required, manpower funding and all. So I think a concentrated effort need to be done so that we can do it forward. But I think that's the most important point, and if we can try and drive it, I think we can make really some good inroad, whether into registration or the regulations or any kind of legislation. Yeah, thank you. Sorry to take your time, sir.
I'll just say a line. I think I agree with Rupesh about the importance of this, but we are a long way off from really being able to do it well because of the shortage of people involved in the care of ocular trauma. So first, you have to get down to establishing the infrastructure on ophthalmic trauma in most institutions. There's some dedicated people are involved in this before we can go some way in getting the data.
Yes, agree.
Let's move on. Rupesh, can you and Dr. Purendra go ahead, conduct the second half of the sessions and introduce the first speaker, Dr. Manish Bapai, please.
I think with that, we completed the first 60 minutes, the first innings, the T20, and I think we'll open up with the next half of the innings with almost like you can call Rishabh Pant of APOTS, right, Manish? And he is the guy who comes up with new innovations despite his very busy private practice. And I don't know how we get the energy and time to come up with one innovation after another. And he has got a few patents in his name, which is again very inspiring and something very inspiring for all of us. And we are very honored, Manish, to have you on APODS as our member. So Manish, over to you, and please enlighten us with some of the innovations. Some of the panelists, maybe I can request you to mute your microphone. Thank you.
Thank you, Dr. Rupesh, for invitation, Dr. Gangadhar for inviting me for this talk. I hope you can see my screen. So I have been asked to talk about innovations in extensive ocular trauma management. Yeah, the truth is, whenever we are dealing with patients of extensive or severe ocular trauma, every trauma surgeon is by default innovator, because though there are general principles that are followed by everybody, the surgeon has to think on his feet while operating so that he can give best results to the patients. So coming to introduction, most of the patients who receive the severe ocular trauma injuries are usually young, as we have seen by talk from Dr. Maurya. Most of these injuries are penetrating or perforating injuries, and they are frequently associated with intraocular foreign body. At presentation, patient may have no perception of light or very perception of light, very poor visual acuity, and may require multi-stage procedures. In this talk, I would like to make my points by sharing some videos with you. So this is the first case of penetrating ocular trauma in an industrial accident of a patient who was 30 years old, and he had industrial accident and had visual acuity of query perception of light. He was advised evisceration elsewhere. On CT scan, we could see that there was a large foreign body which was extraocular but intracorneal. So at first stage, first stage was repair of the eye, where the peritomy was done, adequate peritomy was done, and scleral tear repair was done starting at the limbus using 6O Vicryl. The care was taken to reposit the uveal tissue, and then subsequent posterior sutures were taken with hand over hand technique, where the previous suture is used to give traction and exposing the posterior part of the scleral tear, and then the posterior sutures are taken. Once it had reached the medial rectus was tagged and muscle sutures were taken, and like they would take in squint surgery, these muscle sutures are taken, and then the medial rectus muscle was disinserted using the clamp. We could see the large foreign body which was taken out using the superior rectus forceps. The tear extended posteriorly, and the entire extent of the tear could be seen. It was visualized by giving gentle traction by the assistant, and the posterior most extent was sutured. Once that done, the eyeball was formed with balanced salt solution injected 3.5 millimeters posteriorly, and then the muscle was sutured back to its insertion. At the end of first stage, this was the appearance. This was a very large foreign body. 3 weeks post-operatively, the patient was taken up for second stage. He had regained his perception of light. It was brisk, There were some, I would have taken him little earlier, but because of some logistical issues, it was postponed by another week than I would have liked it. But intraoperatively, the capsular excess was done and lensectomy was done using bimanual cannulae through limbal route. And then 25 gauge sclerotomies were made and the lens capsule was removed. Intraoperatively, we could see the organized hemorrhage and there was a scar on the nasal side. So vitrectomy was done to remove the organized vitreous hemorrhage, and we can see the organized hemorrhage in subretinal space. Coming to the area of scar, we have to be very gentle and careful not to tear the retina there, and the membranes and vitreous was removed using the forceps initially before the vitrectomy was done. There was a small retinal tear in the supranasal quadrant, which was localized, and cautery was done. And then the break, another break was seen at 6 o'clock. Laser was done 360 degrees around, including around the breaks and at the scar on the nasal side. Then the cannula was removed on supranasal quadrant, and iridodialysis was repaired by single needle technique, where a needle 90 proline is passed through the edge of the iridodialysis and railroaded out of the eye, and then it is reversed. The course of the needle is reversed, and we can see, use one single needle instead of two needles, and by doing hangback technique, the iridodialysis was repaired. Then the pupilloplasty was done using single pass fourth row technique, where again through paracentesis, the we take a loop out of the eye and then pass the free end 4 times so that it forms a self-locking knot, which can suture the edges of the tone iris back to its position. It's a self-locking suture, and then it is cut through the intraocular scissors. Endos iridectomy was done, and at this point we could see that there was a bullous RD was evolving again from the same break. So fluid air exchange was done to settle the retina, and again the laser was added. Silicone oil injection was done at this stage, and 6 weeks post-operatively, the patient had attached retina with 6/36 best corrected visual acuity. Pupil was round and cornea clear. Almost 4 to 5 months post-operatively, we took up the patient for oil removal and SFIOL. Since there was a scar on nasal side, we went in, made the flaps on the 6 o'clock and 12 o'clock position, and the temporal sclerotomies were used to remove the oil first from the eye, and then the infusion cannula was fixed in the supranasal quadrant. These were 23 gauge sclerotomies. Here, the flute needle is used to on active suction to remove the oil bubbles, the last oil bubble. Then the sclerotomies were made under the flap, which was initially made, and the 3-piece foldable acrylic IOL was injected through 2.8 or 3 millimeter incision, and the leading haptic was externalized. The IOL flipped, and I had to reposition it using microcapsular excess forceps. Once that was done, then the shake hand technique was used to externalize the trailing haptic. Both haptics were tucked in the scleral pockets, which were made, and then the epiretinal membrane, which had formed, and followed by internal limiting membrane peeling was done over the macular area. So we had attached retina. The section was sutured with Teno ethicon, and the conjunctival and flap closure was done using fibrin glue. So this patient did very well in course of time, and he had attached retina, central lens, and the patient had 6/24 vision 1 month post oil removal and 6/18 parts 6 months post oil removal. The second case is that of 42-year-old male who had penetrating trauma while working in a stone quarry, and he had no perception of light. We could see a large foreign body intraocularly on CT scan. So we can see disorganized globe around the large foreign body. Again, there was a tear, similar tear on the nasal side, scleral tear. We again started at the limbus. Again, similar pattern was followed so as to that we could close the eyeball. The scleral tear in toto, the medial rectus had to be disinserted, and the posterior extent, which was lesser than previous case, this extent was localized, and posterior most suture was taken so as to close the eyeball. In this case, since there was a foreign body, we went in at the primary sitting. Initially, hyphema, organized blood, hyphema was removed. Lensectomy was done through limbal route. And then we could see a large foreign body which was sitting on the retinal surface. It was this was stone, so very difficult to pick up. The vitrectomy was done to release the all adhesions from the retina of the foreign body, and then the sclerotomy on supratemporal quadrant was enlarged, and then we used the claw forceps, which was used to pick up the foreign body from retinal surface and hold it in pupillary plane, while the other hand was used to make almost 180-degree limbal incision, and the foreign body was removed using this superior rectus force. It was a fairly large foreign body. The section was sutured with interrupted sutures. We did attempt to complete the surgery with induction of PVD, but it could not be induced. And at that particular point of time, we had to abandon this particular case. So this was a large foreign body. This is another innovation which is introduced by Dr. Ferenc Kuhn, and this is.
We would like to wind up just in interest of time.
Yeah. All right. So this is. I'll just take half a minute for this video. It's a chorioretinectomy, which is a new innovation which is there, where they do 100% diathermy to the sclera and the choroid and the retina are dissected to the bare sclera, which helps in reducing the PVR changes in post-operative cases. So coming to the innovations, I will just talk for a couple of minutes on this claw, which was developed by us in 2014, and it has the specialty is that it has a claw-shaped prongs which can be retracted, and they can be moved forward to pick up the foreign body, the large and non-magnetic foreign bodies. The claw can open almost up to 8 millimeters. These have been used extensively by Dr. Natarajan sir in removing the pellet injuries in patients who had received them in Jammu and Kashmir. And the chorioretinectomy has been introduced by Dr. Kuhn, and it is getting acceptance now, and it reduces the chances of PVR changes at later stage. So there is a lot of literature which is available, which says that up to 1/3 of the patients receive some kind of vision, even if they present with no perception of light. And there are landmark papers by Dr. Rupesh Agrawal and Dr. Mehul Shah in this. And to conclude my talk, I would like to say that presenting visual acuity of no perception of light or gross RAPD is not an indication of primary enucleation. It should be considered in very rare cases where tissue injury cannot be sutured back, and many patients require multi-staged approach. Surgeon must assess the situation at each stage pre-operatively and intraoperatively, and use innovative techniques for surgical approach in these cases. A significant number of eyes may gain some amount of vision, including ambulatory vision, and innovations like iris repair techniques, scleral fixation of IOLs, chorioretinectomy instrumentation helps us in getting better results for our patients in extensively traumatized eyes. I would like to acknowledge Dr. Sangeet Mittal for giving his video, and I would like to thank you all for patient hearing. Thank you.
Thank you, Manish, and thank you. APOTAS is really thankful to you, and rather all the trauma fraternity for giving these innovations to the trauma field. Thank you very much. Now, in the interest of time, we like to move ahead and with another very interesting talk and not commonly heard, and I'm myself interested in listening to talk from Professor Feng Yun from China, Beijing. And this is the first time she will be speaking to us in many symposium we had, and we all will be interested in learning from her about her concept about the management of the ocular surface and some of the corneal microperforation. Over to you, Prof.
Thank you, Professor, for the invitation, and very nicely to have you here. And I will share with you this presentation. Can you hear the screen now? Is that okay?
We don't see the screen yet.
Not yet.
Not yet. Click on the share screen.
Currently, it's okay.
Yeah, it's coming up.
Okay.
Just go for a full screen.
Yes. Okay.
Yeah.
Okay.
Yeah.
My topic here is very common in the trauma, and but sometimes it's lead very bad consequence. Is corneal microperforation, because many professors have shared with very severe trauma, and we always share our experience on the very severe one. But sometimes corneal perforation can derive from a variety of disorders, but they may lead a very devastating ocular consequence. After infection and traumatic inflammatory eye perforations are the most frequent etiology. And we can make the diagnosis very easy because they have the leakage, and a CTO test can be helpful. And we can clearly see the CTO test for positive for the diagnosis. But for some cases, there's if the micro perforation is not very big, it's very small, and with the intraocular pressure decrease, and sometimes it's sealed. So you can't see the CTO test positive, but you can push on the eyeballs if you give some pressure, and the CTO test will be again for the positive. And sometimes with the severe of corneal lesions, like the corneal lesion is white, so it's difficult to tell is have the micro perforation or not. For those things, we need to pay attention to. And the key to management is of the two part is treat the cause or reconstitute the global. And the causes for the corneal perforation include according to the AAO guideline, and it's about those size can caused by trauma. It's also very common, and also keratitis. We have many infections and non-infections. Mostly micro perforation happens in neutrophilic keratitis, and also many infectious disease, and also some autoimmune disease. And for some we need to pay attention to in this meeting. I want to emphasize is less common that the anterior chamber is not shallow, and it seems it's nothing special. It's just a thinning of the cornea, but there is a big pigment on the wood. It's just a little sign, but it's also have the evidence that maybe they have a macro perforation, because the brown pigment from the iris in the wood itself sometimes it exits the fluid from the eye, and then the iris the pigment is attached to the perforation, and plug in the hole. So it's when you check the patients, and it seems the cornea is fine, but they have some a little bit pigment. So it's special, pay attention to it. Sometimes they already have the microperforation, and they may be the unstable, but sometimes it's stable. So you need to judge, and also have some infectious disease, and it's just as I said, is have the round, the white or swollen cornea, and it's hard to tell. It looks like the cornea is not very thin, but actually they have the micro perforation already. And the brown spot is cornea perforation in the center of the cornea, also maybe hard to detect. And one clue can be pigmentation in the area of the perforation, which may be left behind after the iris plug in the hole. But it's not a staphyloma. I think it's just a little bit, so that we need to pay attention to. And for the treatment, is optimizing the healing while taking care of the underlying causes. So the management and perforation, we have the medical part is treat ending cause, like some autoimmune disease, because there's always have the melting, like Stroll syndrome and SSE or rheumatic disease. They sometimes have the autoimmune melting on the cornea, and if you can't treat the system systematically, you can't hold the cornea to heal. And sometimes we use the proteinase inhibitors to oral take those medications and to stop to prevent the collagen from melting. And also antibiotics are very important for topical and systemic. I will show behind. And also have the aqueous humor suppressor is important. It's a patient for the Stroll syndrome, but it's a severe one, and he have the double eye. For both eye have the corneal perforation, and with the cornea with the anterior chamber is disappear, but he has very bad systemically, so we can't do the surgery, and he had treat in the other department first, and then after 10 days the system may become stable, but we see the perforation has been sealed, and I think it's because we gave some medications and with the systematic control, and the heal has, but we can still see a little bit pigmentation. But if we see the OCT from here, we can say the stroma a little bit regeneration is over 10 days after the systematic treatment. And for those patients, they have the perforation, but if we treat nightly, they can heal. They have healed spontaneously and without the surgery. And the stroma has a little bit risk one. You can see they can with times the stroma can regenerate a little bit. So it's prevent from the surgical. But so treat the cause is very important for the autoimmune treatment, and oral steroids or very rheumatologist general treatment is needed.
Can you sum up your talk, please, Dr. Fain?
Sorry?
Can you sum up your talk, please? Because we are short of time.
Okay. And promoting the cornea healing and observation. For some, the important thing is we give the operation. If we give the observation, we need to pay attention for the daily, for the first few days, and begin to leak later. And this another patient, they had a very small leakage, and it seems fine, so it's give the observation, but a week later, he has a very severe infection, and with the cornea transplant, you can see it's very bad results in the follow-up. And what's seen in during the surgery, you can see from it seems a little bit infection, but it's actually grow into the eyeball, and it's all behind the iris. So it's the whole endophthalmitis, but it's just from a very micro perforation. So for those patients have the systemic, they use the topical immunosuppressive on the eye. Those patients we need to pay attention to, need to a very close follow-up. Otherwise, they can't heal, but they have caused a very bad endophthalmitis, and the high risk, and for another traumatic, the high risk of leak and gaps. These patients, if we use surgical treatment, we can use tonic and membrane graft for the irregular patterns. We use the membrane to multi-layer and to suture, and they can heal the micro. It's very quickly and very good management. And sometimes for the iris plug-in, we can use the to glow things, and for a long time we need to run all this. I just make it quick because it's same times. And for small perforations, we can use the scleral flap or the conjunctive flaps also, because it can get the vessels in, and it's prevent from the infections also. And for large perforations, sometimes if you can rule out the infections, we can use the keratopathy PKP to larger piece graft. And laminar transplant is always recommended for corneal surgeon because it's very good results, much better than the penetrating keratopathy. And those patients will use double layer technique to heal the micro. We don't seal them, we just use a small piece to seal the micro perforation, and then we use a small, bigger piece for the double layer transplant. And this will be a huge, very good visual acuity, and to keep the endothelium stay there. And surgical strategy for laminar transplantation is set the tissue and central cornea, keep it clear. Is to gain the very good visual acuity. But be careful of the trauma patients. It's not very stable. This is the patients have a trauma and it's almost over half a year, and his visual acuity is not very bad. It's 0.3, and but he has a complaint of sudden vision loss and for 1 month. And you see it's a little bit fine, and OCT source is not very thin. But if we saw the ultrasound, because the visual acuity is light perception, and if we see the eyeball, we can see a very a choroid hemorrhage in the eyeball. So this because I think the small wound, it's have the thinning, and they have the micro perforation, and then cause the hypotony cause the later choroidal hemorrhage. And then we do.
Sorry, we are running out of time. Can you wrap it in 1 minute, please? Yeah.
Yes, it's almost done. So we get the hemorrhage, so choroidal in the equator one, so and we can see the hemorrhage, and then punch the cornea, and use a very small piece, and to get the clean cornea, and to suture the cornea. And then we only use this one small wound to get all the hemorrhage out. So it's a typical technique. Okay. So these patients have very good results. We can see this is the corneal patch, and all the flat is a very acuity is 20/50. So it's have very good results if you find the reason and get the treatment while this. So the summary is we have the surgical treatment for small micro perforations to get the glow. And most of them we can use the glow, and also have some conjunctive flap for the peripheral one, or have the infection suspected. Amniotic membrane and transplantation is sometimes in some cases is needed. So be careful for the observation patients. So otherwise they maybe have the choroidal hemorrhage, and also the severe endophthalmitis. Okay, thank you for your attention.
Thank you, Professor Jung. And may I request Dr. Tarjani Dave to present her talk on orbital reconstruction, what is new?
Okay, I have it now.
We are short of time. Please restrict to the time limit.
I will, Dr. Best. Thank you very much. I'd like to thank Dr. Ganga, Dr. Rupesh, and Dr. Namrata Sharma for having me here. I'm Tarjini, and I'm going to talk about orbital reconstructions, what is new. I do not have any financial disclosures to make. You will see full face photographs of some of my patients for which we have the consent. Now, I'd briefly like to take you through the objectives of my presentation today. We'll be talking in short about orbital fractures, the way we classify them, the surgical planning, the hidden incisions that are used these days for improved aesthetics, image guidance in orbital reconstruction, the role of 3D printing, the implants used for orbital fracture repair, the need for multidisciplinary care, understanding the complications of orbital fracture repair, and the lessons I have learned along this journey. I will summarize these with 10 pointers. To begin with, I just wanted to share that this is my perspective. It's not all correct or all wrong. It's not all good or all bad. And everybody can have their own perspective of treating orbital trauma. What I'm going to share with you is the sort of protocol that we follow here. Now, when we look at the role of the orbit, it is to protect the eyeball. It provides a cushion around the eyeball. And there are several facial buttress systems which are present to give the facial skeleton its vertical height, its horizontal height, as well as to provide the bony support for mastication. These buttress systems and suture lines are what are involved in orbital trauma, especially one which goes panfacial. Typically, when we talk about orbital fractures, we have the zygomaticofacial maxillary component of fractures. We also have the nasoethmoid fractures, which are more along the central skeleton. You have the blow-in or blow-out fractures, which typically involve the floor of the orbit. This is a blow-out fracture where you see that the contents are prolapsing outwards towards the maxillary sinus, versus a blow-in fracture where you see the contents prolapsing towards the inferior rectus muscle of the orbit. You also have certain sinister ones like the white-eyed blowout fracture where you do not see any signs of trauma at all. But when you image, you out that the inferior rectus muscle is actually entrapped in the maxillary sinus. And this child is more likely to have restriction of elevation as well as depression. There are certain complex situations, especially in the Asian subcontinent where road traffic accidents are taking over as the #1 cause of trauma, who are more likely to see panfacial trauma such as this, where management sort of tends to become complex and is multidisciplinary. When we look at surgical planning for orbital fractures, there is a nomogram to divide the fractures into those that require immediate care versus those that can be operated in couple of weeks, and those where late repair would not be difficult or would not be counterproductive to the outcome. When you have any child with a white-eyed blowout fracture, as you see over here, where muscle movement is restricted, in such patients or in those who have a gross enophthalmos or hypoglobus and those with a non-resolving oculocardiac reflex, you go ahead with immediate reconstruction. Versus this, patients who are borderline have about, a relatively moderate to large size fracture, say more than 50% of the floor, say more than 2 walls involved, and where diplopia and enophthalmos are the main concerns, you can possibly wait for the first 2 weeks to let the periorbital edema settle down so that you can grade the outcome of your repair better on table. And there are certain fractures where you might not see a lot of periocular signs and symptoms. You just want to wait for stabilization to see if the diplopia improves, whether the diplopia was due to nerve injury, or if it doesn't improve, then consider these patients for a late repair. When we talk at fracture repair, we've moved on to a better aesthetic outcome in terms of using hidden incisions. And there are 3 specific incisions that I'd like to mention over here, especially for us to treat the medial wall and the roof as well as the floor. The first one is the eyelid crease incision, where you can hide the incision very beautifully within the natural eyelid crease. and still expose the entire roof and the lateral wall area. You could alternatively use the floor incision, which is transconjunctival, and again does not require incising the skin in the subciliary area and producing lower eyelid complications. And the third one is your transcaruncular incision, popularized by Goldberg, that actually allows you access to the entire medial wall, especially in those complex ones where there is a bony fragment impinging on the optic nerve posteriorly, or where you have associated medial wall fractures. The fourth point I'd like to talk about is the innovation that the image-guided system has brought in. And this is truly revolutionary in the sense that you can have intraoperative guidance of where exactly you are placing your plate for fracture correction, so that you have an excellent outcome in reduction of enophthalmos, as well as avoid complications such as the muscle being shifted from its position due to the plate. So this particular tool is very similar to the GPS that you have on your mobile phone or on your car's global positioning system. And it helps you navigate into the orbit, especially because the orbit is a pyramidal structure and visualization behind the eyeball is limited due to the anatomy. Navigation system helps you in giving that extra boost of precision and accuracy to orbital reconstruction. This is a video of a patient who has a left orbital fracture. Since we are a little short on time, I'm going to run through certain segments. You can see the obvious enophthalmos on the left-hand side. And this is a fracture which has been repaired using the navigation technology. Here is the coronal scan where you're able to see a fracture of the floor and the medial wall. The posteromedial strut was involved. And on a forced ductions test, you will see that the left side is slightly restricted when compared to the right. In such patients, we ask for a particular protocol of CT scan image, which is loaded onto the navigation machine. The defect size can be configured by going through successive coronal scans from anterior to posterior to exactly delineate the fractured segment. Once this part has been done, you go ahead with your routine surgery of transconjunctival incision, placement of your release of all the tissues from the orbit, and yeah, that's the transconjunctival incision, and the tissues are peeled out from the maxillary sinus, and eventually the plate has been placed inside. Once the plate has been placed inside, you can again use your navigation probe. This is the navigation probe in action to tell you whether the posterior part of the plate is actually sitting on the posterior ledge and giving you sort of correction in enophthalmos or reduction of the fracture as you would desire. Just to show you a couple of snapshots, so this is another patient who has undergone a navigational guidance fracture repair. Additional things that you can do with this toy are to mirror image the CT scan, flip it over onto the affected side as you see the red and the white. So this is the mirrored image, and eventually see if your plate is sitting on the mirrored image or not. So this sort of precision is what image guidance can give you. The next advance that I would like to briefly touch upon is 3D printing and its role in orbital reconstructions. 3D printing essentially is a technique by which the facial skeleton is printed, and it is used to either configure patient-specific implants or to understand the morphology of the fracture in extremely complex cases. So what you do over here is load the patient's 2D scans onto the machine and convert it, you crop the area, you convert it to a 3D scan. This is done by a readily available software. Crop the area of your interest and send it to a printer, which can print the facial skeleton. This is a very basic level 3D printer, which utilizes a plastic material to sort of print the facial skeleton. And this is the printing process. It involves two materials, one which gives you the facial skeleton, and second is the support material. The support material dissolves when you put it in a water bath, and it will eventually give you the patient's actual size orbital floor in its real-time dimension for you to configure patient-specific implants in these kind of situations. This is an example where the defect is configured on a 3D printed skull, and the area of the defect is sent to a printer to generate a very patient-specific implant that treats just the area of the fracture. For orbital floor fractures that also involve the rim, this is extremely useful, and you can generate specific implants that help you in correction of not only the floor, but also the orbital rim. Speaking shortly about implants, we've moved on from using a lot of bone grafts to primarily using titanium, and there's a whole variety of titanium available. But the one thing that I'd like to mention is the 3D titanium plate, which comes pre-configured to help you correct the medial wall as well as floor fractures. And it comes in several sizes. And based on your intraoperative calculation, you can use these 3D plates. Bone grafts, especially calvarial bone grafts dissected from the skull bone, still play a role in certain extensive fractures where you'd have lost the orbital rim and you want to reconstruct the orbital rim, or where you have additional segments to reconstruct, like the nasal bone. Bioabsorbable implants like osteomesh is another advance, where essentially there is an implant which over a period of time allows the bone to regenerate in that area. Bioabsorbable implants, they tend to degrade after the fracture has healed through hydrolysis and promote the gradual transfer of functional forces to the healing bone while they are disintegrating. Osteomesh is one such implant that can be configured to fit in the area of your fracture, and over a period of time it promotes osteogenesis and allows new bone to form in that area while the implant itself is disintegrating. So if you follow these patients up over a couple of years, you would have formation of new bone in the area where you originally had a fracture. There is an excellent paper reviewing the use of bioresorbable implants by Dr. Ganga, and all those interested should definitely read this up. The seventh point I wanted to highlight was the need for a multidisciplinary approach, especially for a patient like this, would also require a rhinoplasty. And sometimes for those who have a frontal bone fracture, you might even need to work in sync with a neurosurgeon rather than working in silo. Enophthalmos following fracture repair is one of the commonest complications that you'd see in the hands of an orbital surgeon. And this is one lady who has a floor and a medial wall fracture. If you look at the post-op scan, there is an excellent correction in the fracture, but she still has some amount of enophthalmos. And this probably has to do with the fat atrophy that occurs due to trauma. And these are things that you tend to learn over a period of time, especially when you do post-op scanning over your patients as well. Another lesson that I learned along this path of treating fractures is when you, for instance, this patient with a floor and a medial wall fracture, we assumed that the zygoma component was possibly not very significant since there's not much displacement, and treated only the floor and the medial wall with a suboptimal outcome, as you see over here. So that defect in the zygoma between the zygomaticosphenoid bone is the gap over here, which is resulting in an increased orbital volume, is what also needed to be corrected in this kind of a patient. And one last situation that I'd like to share is this patient where we thought there was gross enophthalmos with the eyeball prolapsing towards the maxillary sinus, all the walls of the orbit broken. And your immediate reaction is to post the patient for a fracture repair. But look at the rest of the scans in this patient. While the eyeball could not be moved clinically during examination, one of the reasons for that was not only the fracture, but it was a fragment that had actually gone inside the eyeball. This patient had an open globe injury with a bone fragment going right through the eyeball. He had a good vision, but he had to be counseled regarding this before taking the patient up for fracture repair. So it's a lesson that I'll never forget in my life. To summarize, I have spoken to you about the orbital fractures, the facial buttress, and the ways we classify orbital fractures, surgical planning, especially in cases who have entrapped muscle who require early care, I briefly spoke about hidden incisions that can give you an aesthetic outcome in orbital reconstruction. We discussed image guidance and the role of navigational systems. We spoke in brief about 3D printing and how it can help you give that extra boost of accuracy to your outcomes. Titanium is the implant of choice in most cases these days. We also discussed multidisciplinary approach with your maxillofacial and neurosurgeon, especially in panfacial trauma. We discussed about enophthalmos and why it occurs in most cases post-repair, and also about the lessons that we learned along the way, where careful examination of radiology is probably one of the most important things. Last but one slide, I'd like to invite all of you to a bonanza on complex cases in oculoplasty that we are hosting on 20th and 21st of March, 2021. We have stellar faculty lineup for the conference, and I hope to see all of you there. Thank you so much.
Thank you, Dr. Tarjini. And this was really great talk. And I'm sure the oculoplasty people on the board must be quite amazed with the way it has advanced. And you can already see Dr. Natarajan is heading to LV Prasad to meet you now. I think he's already in the car and he's there approaching to see you in Hyderabad. Yes, right, yes. Dr. Natarajan? You're probably engaging her for some APOTAS. Anyway, we'll go ahead with the last talk for the day, which is by Professor Angor Wang from Taiwan, who is the first time speaking to us, and we have heard he has done wonderful work related to neuro-ophthalmology and particularly in the field of traumatic optic neuropathy. So, Professor Angor Wang, to you. Thank you very much.
Thank you, Ramesh. Today, thank you for inviting me here. And today I'm going to talk about updates in the management of traumatic optic neuropathy and no financial disclosures. And traumatic optic neuropathy has an incidence about 0.7 to 2.5 following head trauma. And the prevalence rate in the general population is about 1 in a million at United Kingdom. And there are two types of traumatic optic neuropathy. The direct type is caused by direct or penetrating ocular or orbital injury to the optic nerve. There is a significant anatomic disruption to the optic nerve. Indirect type is caused by the contusional injury to the forehead or the brow region, most commonly in the setting of motor vehicle accident or falls. And it is caused by the transmission of forces to the optic nerve from a distant side without any overt damage to the surrounding tissues. And for the pathogenic mechanism of the indirect type TON, the deformity stress transmitted to the skull from the blunt injury is concentrated in the region of the optic canal. Following trauma, there's a two-stage model. In the first stage, there's an immediate shearing force of the optic nerve axons, and that will cause an irreversible neuronal loss. In the second stage, there's a degree of optic nerve swelling within the tight confine of the optic canal. The ensuring compartment syndrome will further impair the already compromised blood supply to the surviving retinal ganglion cells. If the indirect traumatic optic neuropathy cases was managed conservatively, there is a spontaneous visual recovery rate for about 40 to 60%. As for the prognostic factors, baseline visual acuity has been the most important predictor for the final outcome. Young age or the early surgical timing is associated with a better prognosis. Loss of conscious, lack of visual recovery after 48 hours, absence of the visual evoked response, or the presence of a corneal fracture is associated with poor prognosis. The treatment option for the indirect TON consists of observation, steroid treatment, or the optic canal decompression. The historic support for the steroid use comes from the acute spinal cord injury studies. Patients who received the megadose steroid within 8 hours of their injury had significantly better improvement in the neurologic functions. So a few respective studies in the TON have shown that steroid, both in the standard dose or in a megadose, can increase to 2/3 of the fraction the patient who improved. There's a very large study in the 1990 that we call the AIOS, and that's a large comparative non-randomized study with a total of 133 patients. It was categorized into the untreated corticosteroid and optic corneal groups. And the results showed that visual acuity increased by 3 lines in 32% of the surgery group, 57% of the untreated group, 52% of the steroid group. And they conclude that neither corticosteroid nor optic corneal surgery could be considered as the standard care for the patient with indirect TON. And Dr. Patrick Uwama had did a Cochrane review of in 2013, and they found that only one study met the selection criteria of a double mask placebo control group. And this study have 31 patients, and it was divided into the steroid group and the placebo group. And the visual improvement rate occurs in 53% of the placebo group and 68% of the treatment group. And the difference was not statistically significant. And the American Academy of Ophthalmology had a report on 2020, and they reviewed the literature on 2020 and from the PubMed database. And in the 172 studies, they found 32 studies met all the study criteria. And in these 32 studies, no study met the criteria for the level 1 evidence. And they found 7 studies focused on the corticosteroid effect. And they conclude that the corticosteroid did not have a uniformly better outcome than observation alone. Here is the table for the 7 studies. And you can see that 3 studies show no difference for the steroid effect and the observation alone. And the 2 studies show no control groups. 1 study show observation have a better outcome, and 1 study show steroid have a better outcome. So there's no uniform better outcome for the steroid use. The historic support for the surgical treatment comes from several uncontrolled and retrospective studies. And in the past time, decompression for the TON was a major undertaking using open neurosurgical approach. And for the last 20 years, and it has been changed into a minimal invasive endoscopic transnasal approach, which is associated with much less complications. And let's look back at the IONTS study again. In that study, there was no specific protocol for patient selection or surgical technique of the optic corneal decompression. The result shows that the visual acuity improvement only with 32% in the surgical group. That's the lowest one in the 3 group. And in 2021, there's a review article from China. They have reviewed 23 studies from 1997. And among these 23 studies, we found there are 12 studies with patient number over 25 patients. And in these 12 studies, the improvement rate ranges from 9.5% to 81%. That's a quite large range. And but if you look into detail, you will find that most of them report an improvement rate of 45 to 65%, which is quite similar to the spontaneous recovery rate. And let's look at the AAO report in 2020 again. In this report, they found 20 studies focused on the effect of the optic corneal decompression. These 20 studies include 3 level 2 and 17 level 3 studies. And they conclude that although the visual improvement was noted after the decompression, however, study that directly compares surgery with medical therapy did not report uniformly improved the outcomes after the decompression. This was the table for the 20 studies, and you can see that among these 20 studies, 13 studies was without control group, and 2 studies without statistic analysis, and 5 studies show no statistic difference between the surgical decompression and the steroid use. So in summary, despite many reports of visual improvement with corticosteroid or optic corneal decompression for indirect TON, current evidence does not demonstrate a consistent increased benefit for either corticosteroid or optic corneal decompression. No consensus exists from the study published to date on a preferred standard treatment for indirect TON. Treatment strategy should be customized for each individual patient. We should emphasize the importance of informing the current evidence and the potential side effects of either interventions. Thank you for your attention.
Thank you, Professor Wang. Really appreciate you taking the trouble to share your knowledge, experience, and compilation of evidence for evidence-based management. And we all know that no two traumatic optic neuropathies are the same, whether it's from a blunt injury, a sharp injury, iatrogenic traumatic optic neuropathy, each one is slightly different. So I now throw open the session for a brief discussion. And Dr. Rupesh, would you like to start off the discussion, please?
Thank you, Dr. Ganga. And I think it was a quite a nice session where we have 8 speakers from and speaking about the different aspects. And as Dr. Natarajan mentioned in one of his messages, pole-to-pole surgery. So I think this is something which we're talking about. But I think the tone was set by Dr. Moria, where he mentioned about something about the global level kind of impact. But probably for just to carry on with the second part, and then we'll probably, if time permits, we'll go back to the part 1 again. Just to go back here when we had heard different topics. And I like, Tarjini, you're there. Yeah. So Tarjini, I think this is, you really embarked on something very interesting and something very impressive. Though this is not something of my area of kind of subspecialty, and Dr. Ganga and other people are definitely on that. So where do you foresee we going forward as far as the orbital, the eyelid and all is concerned? And because this is really revolutionized what you have shown, and as Dr. Ganga mentioned, you are taking us to the next millennia. What do you think and what you should be taking forward? Some messages from you for the society.
I believe that as oculoplastics or oculofacial surgeons, each one of us has tried to improve our area of expertise by getting minimally invasive in what we are doing and getting better results aesthetically. So the collaborations we've built with our colleagues from maxillofacial and neurosurgery definitely cannot be belittled. But as a society, I believe as oculoplastic surgeons, we are more geared to handle panfacial trauma in a much better way than what we were 10 years ago. So with the advent of navigational systems, the implants, which are so much better than what we used to have 10 years ago, I'm sure that managing orbital trauma is going to be much, much easier.
Dr. Ganga, you are the expert in the oculoplasty, and you've heard one of your students, means not direct student, but you've been inspiration for all the people, including myself, and also for, I'm sure, for Tarjini also. So what do you think? And I am sure you must be proud with her work. And where do you think we should all be heading towards in this term?
I think, I mean, it's first of all, it's very rewarding to see bright young people coming up on the horizon, telling us we guys should go and retire first, number 1. Number 2 is also to show the beautiful...
Ganga, I want to resonate you.
Yes,
Nati. What about me?
No, you're forever young, you're Markandeya. So you're the bright young generation we are talking about. Anyway, so I think you also highlight the complement between technique and technology. I don't think you can replace one with the other. So the technique is very important. That's why we are human beings. We are technicians. I'm just saying I'm a glorified technician. We do it. At the same time, you have to embrace new technology. And I'm proud to say that oculoplastics, for example, you guys are using navigation for positioning toric lenses and anterior segment surgery in the past few years. We've been using navigation surgery for the past 15, 20 years.
Yes.
You guys don't even have a patient-specific implant for intraocular surgeries, right? Whereas we now have patient-specific implants for orbital reconstruction. So we dare say that we are miles ahead of you all. But having said that, the message I think I want to get home to all the ophthalmologists is, you ophthalmologists or pure ocular specialists work with a good oculoplastic surgeon. And the message to the oculoplastic surgeon in turn is to work with a craniomaxillofacial surgeon. So together we make the patient whole. I think that will be the future, and keep embracing technology. I always say, be not the first by whom the new is tried, nor yet the last to lay the old aside, which means we have to give away some old forgotten principles. Manish has taught us about innovations, improvisations, thinking on your feet all the time so that we deliver the best for the patient.
Manish, now coming to you, I think you and the same thing as, and we have spent some good time together at Shankar Netralaya back old in that 1999-2000. I think this is really a phenomenal journey. And how do you kind of, again, the retina surgery has improvised and all, again, with your innovations, do you still think there is still a scope of further improvement? Even we are talking about now current generation is really we thinking in the cutting edge, but do you still foresee that we should be able to help our patients more with the new innovations?
Oh, yes, definitely. I think there are many areas in vitreoretinal surgery where the innovations can go a long way. For example, we are still looking for perfect intraocular tamponade, for which can be probably which can replace vitreous and be left for really long time without causing any intraocular side effects. There are many other areas where we are still looking for better outcomes. And as far as trauma is concerned, trying to get the eyeball closed and getting the useful vision or ambulatory vision, there are every case, as I said in my talk, every case is a challenge. Every case needs innovation by surgeon while thinking on his feet. You follow the basic principles, that is most important, and you need to improvise on that.
Thanks, Manish, again. And any other points for Manish, or before we move to Dr. Ganga?
Rupesh,
Yeah, please, sir. Please, sir.
I just wanted to say, I recently had a patient about a year back. The patient had some wire injury, and the wire was seen in the limbus, and probably the resident in KEM was trying to take the wire from the AC, but I think couldn't see, it went into the iris. And after that, Dr. Sachin took over the patient, and he tried opening through the Pascana region or behind the iris. He couldn't see. He called me. I tried for 10 minutes, and I told him, see, there's no question of trial and error. We can't see, and I can't see, and I think ophthalmology is not blind. Better close it, and we'll decide what to do. And I found my endoscope didn't work. So I sent it to Dr. What's our friend in LV Prasad surgery, we are using endoscope.
Raja.
Rajiv Reddy Papuru.
Rajiv Reddy, yes.
Rajiv Reddy.
Okay. Rajiv Reddy. So I sent him and he removed it. We are actually trying to write up. So what I wanted to say, however experienced you are, and second is we saw the foreign body, we went in, we couldn't see. Again, we did a CT, it was a moved here and we couldn't see. And I think, I don't know what, finally I said there's no role of me because nothing was intraocular. And I think, I don't know whom she discussed, and finally removed it in the second surgery. But the thing is, both times the patients were patient. Patient believed that we can't see, so we are not able to remove. That's because we were truthful. So I think, however great surgeon and however number of surgeries you have done, I think that particular patient is again another he saying that I've done the maximum, and you can remove any foreign body or you can repair any eye. But I think you have to be most humble. From parents, don't give up. Manish had a no PL. I think no PL is an indication and only in trauma. And I think best is now parents and my propagate any injury including trauma. Do the same day. Do the same day.
The voice is cracking. Maybe
we did most within a week. Yeah. Okay. Now can you hear?
Yeah, yeah.
No?
Yes.
Okay. No, I knew. I think be perseverant, but don't be you're not sure. I think opinion. and absolutely we go here. The patient should be the only beneficiary.
Thank you,
That's
sir.
all I want to say.
Thanks, sir. Thanks. Maybe Professor Wang, you spoke about the traumatic optic neuropathy, and this is the question always been asked to all of us. Will you still give IV methylprednisolone? Because I know the level of evidence, and every now and then it comes up in the Cochrane review and multiple other reviews been published, and Dr. Ganga has also published a very extensive review on this thing. Will you still offer a patient for whatever it is worth for a trial of IV methylprednisolone when the patient is admitted and you diagnose him as traumatic optic neuropathy? We do know that results are not very convincing, but what is your take on the patient?
May I add a question to that before he
Yes,
answers?
sir. Yes, sir, please.
If he were to opt for steroid methylprednisolone,
yes,
how many days after
yes
would he still consider it? And what regimen is he following? Is it the same as for ONDT, 5 days or 500 milligram,
Yes.
1 gram? I would like to know the details from him.
Sure, sir. I think that's a very good question. Thanks, sir. Professor Wang, maybe you want to unmute yourself first? Unmute yourself.
Okay. I think first of all, there's a crash study that shows complication of a higher death rate after using the mega dose of the steroid. So if you are avoiding the mega dose, I think the standard dose, which means the high dose using like 1 gram of methylprednisolone per day, I think that would be safe in common patients. So except for the patient with a severe head injury, so in the severe brain trauma, the steroid should be used very carefully. In a patient with without a severe head trauma, you can standard dose steroid like a methylprednisolone 1 gram per day, used for 3 days, and tapered by oral steroid. I think that can be done. And so in my clinical practice, I still offer the treatment to the patient if the patient doesn't have a severe contraindication.
So if the patient comes late after, say, a day or two, they have visited a local ophthalmologist somewhere else, and then they visit, and what do you suggest? What do you recommend after 3 days?
Because the spinal cord injury emphasize the treatment of steroid within 8 hours, that would be effective for the steroid effect. So the early you use the steroid, the better the outcome. However, in a few patients, if they come maybe 3 or 5 late days after the trauma, I still will give them the treatment as long as we check the eye ground. If the optic nerve has not been becoming pale at that time, usually the optic nerve will become atrophy after maybe 3 to 4 weeks after the trauma. So I think as long as maybe 3 to 5 days after trauma, the steroid still can have the effect to decrease the edema within the optic canal. So to decrease the edema can help the optic nerve to recover from the compartment syndrome. I think that can still be used.
One question, a small question. What will you do? When will you start? When will you start steroids, and when will you go for the optic nerve canal decompression?
I think usually, if you are doing the optic canal decompression, that means in your hospital you have some expertise.
We can refer to them.
Otherwise, you won't consider for the canal decompression. And of course, after using the steroid for 2 to 3 days, if the patient did not recover, that's the timing for you to consult the expertise to come in and to evaluate the condition and to go for the optic canal decompression.
Okay, thank you. Thank you, Professor.
Thanks again. Dr. Ganga, you have any further points to add, or how should we kind of, for all the speakers? You
want to make a couple of points, if you don't mind, Rupesh. First of all, I wanted to thank each and every speaker who immediately accepted our invitation to give a talk. And I think you completely covered everything from data capture to the spectrum of injury to registries to anterior segment, posterior segment trauma, microperforations, orbital reconstructions, and traumatic optic neuropathy. So big thanks to each one of them, and you, Rupesh, for coordinating it, number one. Number two, thanks to OTSI, which was started 25 years ago, Dr. Shukla, Dr. Air Marshal Buparai, for having started the momentum going on ophthalmic trauma or ocular trauma. And you're celebrating your 25th anniversary this year, and your momentous, wonderful CMEs that you've been doing through the year. And we are celebrating the 10th year of APOTS. And I invite every single member who's attending this webinar today and from all AIOS members across the specialty to come join us. So you can act locally, but I want you to think globally and join us and take this cause even further forward. I'd like to specifically and personally thank Dr. Feng Yun from China, Professor Wang from Taiwan, Annette always from Australia, and Eli from Nepal, and our Indian colleagues, Dr. Rajendra Maurya, who actually is a very dynamic hero. He's handsome looking, he's very productive, he's publishing regularly, writing books. Dr. Mehul Shah for his inspirational work, I told you before, clinically, surgically, now really developing a model program for training patients in ophthalmic trauma. Manish for his innovations, and of course, Tarjani, the bright young person on the horizon. I'd like to actually invite Dr. Namrata, if she's still there, to tell us whether we have delivered what we wanted to deliver, if she's satisfied, and what more we can do as APOTS through AIOS to take ophthalmic trauma forward. Dr. Namrata, are you there?
He has given a message to me, and she's very excited with this collaboration. I'm hoping that she's a bit stuck in the another call, but what message she has conveyed is that AIOS is very keen to continue to work with APOTS, and AIOS is very happy to provide support and whatever platform we need for APOTS to continue to take ophthalmic trauma forward. But I think those were the couple of messages, but I don't know whether she can join because she's in another session.
Or Dr. Grover can summarize.
Dr. Grover can summarize. Yeah.
Because he is both AIOS, he is OTS.
Thank you, Ganga. I would just like to thank All India Ophthalmic Society for this opportunity for the Asia Pacific Ocular Trauma Society to have put together this seminar, which would create a much better awareness amongst everybody in India and globally, and would help the cause of ophthalmic trauma. And certainly Asia Pacific job, not just in organizing this scope about the issue and about raising the services to meet the challenge. I think this was a very befitting seminar to have in this period when AIOS was organizing its global webinars, and we are very happy that we could put together this session. Thank you all. Thank you, Ganga. Thank you, Rupesh. Thank you, Namrata.
For a few minutes, Gangadhar Sundar wants you. Namrata, can you join us? We have finished the session. Gangadhar Sundar wants. Ganga,
yeah.
I just called Namrata. She's joining.
Okay, great.
That's very good.
Another good news, Ganga. 2025, AIOS is hosting APO in Delhi.
Oh, wonderful, wonderful.
2024 is Bali.
No, Dr. Namrata.
Dr. Namrata is there.
Yeah. And I just wanted to thank you for giving us the opportunity, but I wanted to hear from you whether we have delivered what we wanted to deliver, what more can APOTS do for AIOS, and how to take AIOS APOTS collaborations further. Thank you.
Okay, surely, Gangadhar, it was absolutely perfect. And thank you so much for organizing this, and thank you for getting both the international and the national. In fact, all our national speakers are also of international fame on board. And thank you, Rupesh and Dr. Gangadhar, both for doing this. And we would take this collaboration further. We can plan out on what we want to do, whether it is related to research or related to clinics or related to, collaborating on a mutual exchange program such as this. But thank you so much. I know it was at a very short notice, but thank you for doing it.
Namrata, a reminder. We had a petition filed at the World Congress of Ocular Trauma regarding advocacy and PIL with regard to prevention of trauma due to crackers.
Yes.
We would request you to follow it up further along with Dr. Natarajan and carry it to its logical conclusion.
So now I know why
Actually,
Dr. Yeah, surely, Doctor.
During
Surely.
the fasted for endophthalmitis and trauma, and Dr. I requested now Dr. Rajiv to contact advocate. So I'm working with the Namrata and we will have to do the PIL.
No,
Dr.
we'll do it.
Namrata?
We'll do it, sir. We'll do it.
Dr. Namrata, I was just wondering, do you think AIOS can have a platform, and is there any precedence where they have a mandatory registry? Let's say we have communicable disease registry or something like that. Do you have any kind of a mandatory registry with AIOS, and can we?
No, we don't.
Not,
we don't have. No, we
can
don't
we set
have
up a
to,
precedence with the trauma
yeah.
then? Because
Yeah,
where people
surely,
have to
surely.
mandatorily report, we can have a very
Yeah.
short form. At least
Surely.
we know
Surely.
little bit of the incidence prevalence
We
kind
can.
of statistics.
We can. You can send
Let's,
the.
Annette and I can work with you on that,
Surely.
and we can have a very short form which people
Sure.
can mandatory, because once AIOS comes on the board and then they put it, I think people will try and follow.
Surely. Sure.
Thank you. Dr. Ganga?
Thank you all once again. I really appreciate all the speakers, the organizers, our leaders, Professor Natarajan, Professor Mukherjee, Dr. Grover, for showing us a way forward, and we'll continue this collaboration. I'd like to thank you all once again. Stay safe, get your vaccine until we meet in person 2022 or 23, it looks like.
We don't.
Take care.
Okay.
Thank you very much.
Take care. Take
Really
care.
appreciate it.
Bye-bye.
Bye, everyone.
Bye-bye. Bye-bye. Thank you, Genga. Thank you, Ravish.
Thank you again.
Thank you, Nataraja.
Yes.
Bye-bye. Thank you.
Bye-bye. Bye-bye.
Thank you. And
Bye-bye.
Thank you.
Right. Thanks, sir.
thank you.
Thanks, Purandar.